Welcome to the weekly Neurology Deep Dive, produced by Amer Gavanini. Today we're taking a close look at a really important new practice guideline. It's focused on spinal bulbar muscular atrophy. And it's aiming to standardize care, not just for motor function, but for, well, everything this multi-system condition throws at patients.
That's right. And before we really jump in, just a reminder for everyone listening, this deep dive is purely for educational purposes. We don't have any commercial goals here. Think of this as a summary. For the full details, we absolutely recommend you go and read the complete practice guideline paper.
Good point.
So, spinal bulbar muscular atrophy, or Kennedy disease as some know it, it's an X-linked recessive neuromuscular disorder. It's caused by an expanded cytosine adenine guanine repeat, we're talking 38 or more repeats, in the androgen receptor gene.
And the guideline brings up a key point about prevalence, doesn't it? Something quite striking.
It really does. It highlights a significantly elevated prevalence, 14.7 per 100,000, specifically among people identifying as First Nations and Métis in Western Canada. That figure really underscores why we need standardized care, but also, crucially, culturally responsive care.
Absolutely. It makes it a necessity.
Exactly. And clinically, you're looking at progressive limb and bulbar weakness. There's a high mortality risk, median age is around 65, often due to respiratory problems like dysfunction and aspiration pneumonia. But it goes wider than that: cardiac issues, endocrine, metabolic, sensory manifestations. It's complex.
Which points towards needing a broad team right from the start.
Precisely. A multidisciplinary approach is fundamental.
Okay, let's start with the very first step then. Getting the diagnosis confirmed and setting up that care structure. What's the non-negotiable for diagnosis according to the guideline?
It's got to be genetic testing. You need confirmation of that increased cytosine adenine guanine repeat number 38 or more in the androgen receptor gene. That's the definitive diagnostic step.
And once you have that confirmation,
then formal genetic counseling is essential. It's not just optional. The counseling needs to cover quite a bit: the range for age of onset, the specific symptoms people might expect, the disease's natural history, how it's transmitted, and of course the risk to other family members.
And you mentioned the androgen receptor gene. The guideline clarifies something about hormone levels, right?
Yes, a very practical point for clinicians. Testosterone levels are not useful for diagnosis here. Often, maybe even usually, the hormone levels are within the normal range in people with spinal bulbar muscular atrophy, so it's not a reliable marker.
Good to know. So diagnosis secured, counseling done. How should the ongoing management be structured?
The strong recommendation is for management by multidisciplinary teams. Preferably, these should be within established motor neuron disease clinics, as they're often set up to handle this kind of complexity. It helps address both the motor and those tricky non-motor symptoms effectively.
And who needs to be on this team? It sounds comprehensive.
It is. You need neurologists, physiatrists, pulmonologists, cardiologists, dietitians, endocrinologists, geneticists, plus all the therapists: speech, physical, occupational, respiratory. And importantly, given the need for culturally responsive care we discussed, social workers and Indigenous patient navigators or cultural support personnel are vital members.
That's a very robust team structure. But you mentioned it's a strong recommendation based on very low certainty evidence. How do we square that?
That's a great question. It highlights the difference between needing randomized controlled trial data and, well, clinical necessity. We don't have those big trials proving this team structure is better in terms of hard data outputs. But expert consensus, clinical experience, it all points to this being the best way, really the only way, to manage such a complex multi-system illness effectively. So the recommendation is strong based on that need. The guideline suggests yearly assessments by the team, or more often if needed.
And adapting to patient needs.
Absolutely. Using virtual care should definitely be considered to help with travel and mobility challenges many patients face.
Okay, that sets the foundation. Now, let's zero in on the major risks: cardiac and respiratory. These are often life-limiting. Why the mandatory cardiac monitoring?
Because there's a serious risk of potentially life-threatening heart rhythm problems, dysrhythmias. Most commonly, it's Brugada syndrome. This can lead to sudden cardiac events, so monitoring is absolutely crucial.
What does that initial cardiac workup involve?
It's thorough. A cardiology consult, a 12-lead electrocardiogram, an ambulatory electrocardiogram like a Holter monitor, and an echocardiogram. And it doesn't stop there. Follow-up needs to happen every 1 to 2 years, including repeating the 12-lead and ambulatory electrocardiograms.
For patients identified with this Brugada risk, what are the really critical warnings or advice they need?
Several key things. They must avoid certain drugs known to potentially cause ST segment elevation. There are lists available. They also need to avoid cocaine, cannabis, and excessive alcohol. And managing fever is critical. Treat it promptly with antipyretics, like acetaminophen or ibuprofen. Any unexplained fainting or syncope needs immediate investigation by a cardiologist or electrophysiologist to check for ventricular arrhythmias or Brugada syndrome.
Extremely important points. Now, shifting to the lungs. Respiratory failure is a major cause of mortality. What specific tests are needed for that annual respiratory check?
The goal is to catch weakness, sleep-disordered breathing, and problems clearing airways early. So the measures include upright and supine forced vital capacity, slow vital capacity, maximal inspiratory pressures, maximal expiratory pressures, sniff nasal inspiratory pressures, peak cough flow, and overnight oximetry to check oxygen levels during sleep.
That's a comprehensive set. Is there a specific threshold for intervening on airway clearance?
Yes, the guideline gives a clear cutoff. Airway clearance techniques, things like assisted coughing, need to be started when the peak cough flow drops below 270 liters per minute. And it's not just starting them. Patients need expert training on how to use these techniques properly. They also need to be educated about laryngospasm, what it is, the signs, and how to manage it.
And if respiratory failure does develop?
If chronic respiratory failure is diagnosed, then non-invasive ventilation, usually with a mask interface, should be started. We also need to think about managing bronchial secretions. Pharmacotherapy like mucolytics, maybe a beta receptor antagonist, nebulized saline, or nebulized ipratropium can be considered.
Okay, that covers the two big immediate safety risks. Let's move on to the next section. Bulbar issues, nutrition, and metabolic care. Dysphagia or swallowing difficulty is common. How should nutritional status be tracked?
It needs regular attention. Measuring weight and body mass index should happen yearly. A dietitian needs to be involved regularly, reviewing their diet, fluid intake, and any supplements, thinking about calories, nutrients, vitamins. And clinicians need to keep concurrent metabolic issues in mind, like non-alcoholic fatty liver disease, diabetes, or bone health problems.
How is swallowing function itself assessed?
It should be assessed regularly. This can be done clinically, by observing the patient swallow, asking about symptoms, or more formally with a video fluoroscopy swallowing study, which is an X-ray video taken while the patient swallows different consistencies.
When does the conversation turn towards considering a gastrostomy, a feeding tube?
The guideline suggests specific criteria to trigger that discussion. Things like losing 10% of their baseline body weight. Or if their body mass index drops below 18.5 for adults up to age 70, or below 21 if they're over 70. Also, a high risk of aspiration pneumonia, or if meals are just taking an excessively long time to finish. There's also a practical point. If their respiratory function is already quite low, say a forced vital capacity under 50%, then a radiologically inserted gastrostomy might be a safer option than an endoscopic one.
Makes sense. Now, the endocrine and metabolic side, especially considering the androgen receptor link, what's involved in that screening?
Patients need referral to an expert clinician, for this could be their primary care provider, an internist, or an endocrinologist. This should happen at diagnosis and then annually. The initial screen involves a physical exam looking at the thyroid, checking for gynecomastia, measuring testes volume, and blood work. A lipid profile, diabetes screen, thyroid tests including thyroid-stimulating hormone and free thyroxine, liver enzymes, and markers for bone metabolism. Imaging for non-alcoholic fatty liver disease or checking bone mineral density might also be part of it. And importantly, addressing symptoms of androgen insensitivity, things like sexual dysfunction or lower urinary tract symptoms.
This brings us back to the androgen receptor. The guideline gives a very strong warning about one particular treatment, doesn't it?
It does, and it's critical. Testosterone supplementation should absolutely not be used in spinal bulbar muscular atrophy. The evidence, mainly from animal models, links testosterone exposure to the disease process itself. It might actually worsen the condition.
So a definite contraindication.
Absolutely. On the other hand, for patients who have an elevated body mass index, counseling on weight loss is recommended, as it might help reduce the risk of other endocrine problems.
Okay, really vital guidance there. Let's move to our final section, focusing on limb symptoms, functional independence, and some special considerations. For limb weakness and related issues, what's the approach?
The main goals are maintaining functional independence for as long as possible and preventing falls, which is a big risk. This involves strategies like home and workplace assessments to identify hazards, making modifications to the property, and using equipment like wheelchairs or orthoses when needed. And it's worth remembering, sensory symptoms are common too and contribute to imbalance. So fall prevention has to tackle both the motor and sensory problems.
What about specific symptoms like tremor or muscle cramps? Any recommended treatments?
For tremor, if it's causing distress or really limiting function, propranolol is suggested as a conditional option. Conditional meaning you need to weigh the benefits and risks and monitor closely. For muscle cramps, the first steps are often simple things: ensuring adequate hydration, regular stretching, maybe trying tonic water for the quinine. If those aren't enough, gabapentinoids or baclofen can be considered. And pain, separate from cramps, needs its own assessment and a multimodal treatment plan.
And exercise. We often get questions about this in neuromuscular conditions.
The guideline says exercise should not be discouraged. Instead, the recommendation is for an individually tailored program. The key is that it needs to be adjusted right away if the patient experiences worsening fatigue, pain, or weakness. Listen to the body.
Good practical advice. Now let's touch upon female carriers.
Yes, providers need to specifically ask female carriers, those with 38 or more repeats, about any neurologic symptoms they might have. Although it's typically milder, they can develop symptoms like cramps or tremor, especially as they get older. If they do have symptoms, the management strategy should basically follow the same principles used for males with the condition.
And finally, let's revisit the crucial aspect of culturally appropriate care, particularly for the First Nations and Métis populations in Canada, where prevalence is high.
This is a really important section with strong recommendations. Care must be culturally appropriate, and it needs to be guided by the specific First Nations and Métis communities involved. Clinic visits should happen in the patient's preferred language, using translation support if necessary. Family members should be actively encouraged and supported to attend appointments, and the clinic staff have a responsibility to connect with existing community supports like Indigenous health navigators, knowledge holders, or elders to ensure care isn't fragmented. Plus, there's a need for training for the whole clinical team in trauma-informed care, cultural safety, and cultural responsiveness. It's essential.
It sounds like this guideline really provides a comprehensive roadmap for neurologists, a clear step-by-step standard, addressing everything from diagnosis to the life-threatening risks, daily function, and importantly, that culturally responsive care.
It really does. It maps out that necessary multidisciplinary approach across all these different domains. The emphasis on culturally sensitive inclusion is a major step forward. It defines a standard of quality care.
But, and this is often the case with rarer diseases, there's a final thought to leave our listeners with concerning the evidence itself.
That's right. Despite having 41 recommendations, the authors are upfront about the evidence base. For many management topics in spinal bulbar muscular atrophy, high-quality evidence, especially from randomized controlled trials, is, well, lacking.
So many of these strong recommendations are based on
Primarily on expert consensus, and also on extrapolating knowledge from managing other motor neuron diseases, particularly amyotrophic lateral sclerosis.
which really highlights a critical need, doesn't it?
Absolutely. It underscores the urgent need for more dedicated research focused specifically on spinal bulbar muscular atrophy. We need high-certainty data to guide truly effective treatments that are unique to this condition.
A crucial point for the future. Thank you for walking us through that.
A necessary goal, definitely.
And thank you for joining us for this deep dive. As we mentioned at the start, we strongly encourage you to read the full paper for the complete context and all the detailed recommendations within this vital clinical practice guideline.